Hello, everybody. I'm Allan Kellehear. I'm the professor in health and social care at Northumbria University in the UK. And it's a great pleasure to be here talking to you today. I wish I could be there in Brazil, but it's not to be this time, but maybe in the next year or two, I'll get to visit you all. But it's a great pleasure and a great honor for me to speak to you today, particularly at this point in your history, and particularly the history of the Brazilian palliative care policy, because for you, this is an historical moment. And it's historical in the sense that Brazil is moving forward, developing its palliative care from clinical models to public health models. And we're doing this around the world in many different places now, but it's wonderful to see Brazil providing this kind of leadership, particularly in South America. And I think I also want to say hello to Professor Alexander Silva as well, my brother in public health. He is the founder, as all of you know, of the Favela Compassiva. I hope I pronounced that right, Favela Compassiva. And it is no doubt through his pioneering efforts and his influence in Brazil that this has helped bring the public health perspective forward in Brazilian palliative care policy. So hello, Alexandra. I hope one day we'll meet one soon. I've been asked this today to introduce the public health approach to palliative care, to remind people who are at this meeting what the public health palliative care approach is all about, to remind you why we do this, why we do public health palliative care, and particularly why we do compassionate communities, and because compassionate communities are such an important plank, an important part, if you like, of the public health approach to palliative care. So I only have about 25 minutes or so to speak about these things, so we'll begin now. First of all, I want to be able to remind people that when we speak about public health in palliative care, we are not talking about the surveillance sciences. We're not talking about epidemiology or health services research or bench science or computer modeling. These are also public health approaches, but in this particular case, when we speak about public health in palliative care, we are speaking about health promotion in palliative care. And when we speak about health promotion, we are trying to balance an understanding of health and well-being, as well as disease and illness at the end of life. We're keeping those two visions, if you like, in balance that drive our work forward. We are also referring to the new public health practice methods. These are things like community development and health literacy, sometimes also called in our field end-of-life literacy or death literacy. We're talking about civic policy development and social ecology, services redesign. All of these kinds of methods are what we mean by a public health approach to palliative care. So why do we do this? I think it's very important to start off with the basics, to remind ourselves what are the basics here. And it's a popular misunderstanding, even amongst professionals, that palliative care is just about care of the dying. But it's not. It's never been the mission that dying people alone benefit from palliative care. Palliative care, hospice and palliative care have always cared for people living with life-limiting illnesses, their caregivers, their families, their friends, the people who love them, their caregivers, and also those who live with grief and bereavement. They are the big three: dying people, caregivers, grief and bereavement. And I always say grief and bereavement because people who live with life-limiting illnesses and people who are providing care for them also grieve. They grieve about a whole range of things. So bereavement is a specific form of grief, which is about grieving after the person has died, after a loved one has died. bereavement as a specific source of grief around the death of someone. But grief occurs to people while they're giving care, and grief occurs while people are dying or living with a life-limiting illness. So it's very important that when we speak about palliative care, we remember these three populations. And that brings me to the 95% rule. The 95% rule says that dying people and caregivers and the bereaved spend less than 5% of their time in front of a doctor or a nurse, or a volunteer for that matter. Often a volunteer, you spend more time with them. But doctors and nurses, certainly, healthcare professionals, only really are in front of dying people or caregivers or the bereaved less than 5% of the time. 95% of the time, dying people are alone or with family or with friends or with their workmates or with their neighbors or with their animal companions or with the stereo system or with the internet. If you are interested in end-of-life care, then that 95% is where the action is. That's where we really need to do our work. Not that 5% of the time when there's a doctor there or when there is a nurse there or a healthcare team. No. The 95% is that time when those people are not there at all. So the real action, the bigger period within which we provide palliative care should be, in fact, that 95%. The other thing that we need to remember is what I call the social epidemiology of dying, caregiving, and grief. And the interesting thing about the social epidemiology of dying is that it's very similar, surprisingly, to the epidemiological profile of caregiving and grief and bereavement. Very similar. And what is that social epidemiology? If we look at dying, dying is not a particularly complicated thing to do. There are complicated dying, and there are some complex cases of dying, and specialist palliative care services are particularly useful in the last hours and days for some people whose dying is complicated. But for most people, and for most of the time, dying is not that complicated. What is complicated, what is difficult, is what comes along with dying, what comes along for the ride. It's the anxiety. It's the depression. It's the loneliness. It's the social isolation. It's the social rejection, the stigma, the financial troubles, the job loss, the lost school days, the lost work days, and worse, sudden death, the premature deaths, the suicides. And all of those things and more are amenable to prevention and harm reduction and early intervention. That means that we can prevent some of these things from happening. And if we can't prevent them from happening, we can reduce their harms. We can minimize their negative impacts. As long as we act early. These are the public health principles, and they're designed with the idea that dying doesn't occur in 24 hours. It takes days and weeks and months, and caregiving goes on for months and years sometimes. And people who live with bereavement don't suffer from bereavement, don't live with bereavement for 6 weeks. They don't even live with it for 6 months. They don't even live with it for 6 years. Grief is forever. So the public health question is, what are our forever strategies to address this? That's when we talk about maximizing what we call social assets and well-being. The problem with health professionals' engagement with living with dying and living with long-term caregiving and living with grief or bereavement is that we tend to see the problems. Because as professionals, we always want to know what the problems are so we can fix them. It's a blind spot. It's a blind spot. And we therefore very easily overlook the good things that happen. People are always surprised when I say good things, especially good things about dying, for example. But there are good things that happen in dying. Dying doesn't take a day. Living with your mortality takes a long time. And during that time, many people report, if you review the studies, the first person accounts of living with dying, you will see the abundance of stories about love, about friendship, about closer intimacy, about community, in fact. The meaning-making processes that go on. What do you think? People who are dying are just sitting around watching TV. They're not thinking anything. They're trying to make sense of this. They're trying to make sense of their lives, their relationships, their future. The Americans, particularly the Americans, when I say the Americans, I mean the people to the north of you, the USA. Their literature is full of books that talk about the fear of death. The Americans are very frightened. North Americans are very frightened of death. Under-publicized, under-recognized is courage and resilience in the face of death. These things occur. Again, if you look at the first-person accounts of living with dying, living with bereavement, living with caregiving, if you look at the few studies we have from the social and behavioral sciences about these kinds of lifestyles and experiences, you will be surprised at how dominant the idea of courage and resilience is as a balance against the fear of death. There's also reminiscence. People remember their lives. They go over their lives, not just dying people, but people who are caregiving. They remember their relationships with that person they love, who they're caring for. Their minds go back again and again. They remember not only the bad times, but they remember the good times. They are also meaning-making. They are also piecing a story together to make their lives significant, memorable, loving, something to take into the future. Now, the task of health promotion, the task of the public health approach, is to maximize those kinds of experiences against the experiences of suffering so well documented by the medical and nursing literature, research literature. Only by being able to balance, to maximize those, what we call social assets and the well-being aspects of these human experiences, can we really bring a stronger arsenal to the negative aspects of life towards the end. It's also important, public health is also important in terms of quality and continuity of care, because doctors and nurses only spend a small amount of time with people. That continuity of care must come from somewhere else. And it must come from us. It must come from the community, from you and me, from the neighbors, from the workplaces, from our schools, from our temples and churches and our mosques. If it doesn't come from there, we have a quality issue. We have a quality issue. That joined up idea, that partnership between civic society and healthcare is crucial. Absolutely crucial for an effective healthcare approach in any civilized society. And this basically means that palliative care is everybody's responsibility. Absolutely everybody's responsibility. The idea that palliative care, when you think about palliative care and hospice and palliative care, you think of it maybe, as a professional service. Oh, yes, it is a professional service. Health is a professional service, but no civil society confines its healthcare to doctors and nurses and social workers and chaplains and allied health people. When you get in the car, you have to understand that your car is designed not just for performance, but for health and safety. Cars are designed better every year for your health, for your safety. You have a responsibility when you get in that car to wear your seatbelt. The doctor is not going to put a seatbelt on you. You have to put the seatbelt on. When you ride a bicycle, you should actually wear a helmet. And if you're going to have sex with strangers, you most certainly should wear a condom. Now, these are basic things. Same with drug and alcohol. You know that you should drink in moderation. You should not have more than 5 shots of vodka before lunchtime, right? You're supposed to moderate your drug and alcohol intake. You're supposed to eat well. You're not supposed to allow yourself to get too big, and you should exercise. All of these things are called health promotion activities. These are health promotion activities. Because if you are healthy, you eat right and you exercise and you have safe workplace and a safe home, a good roof over your head that keeps the rain out. These things not only help you live longer, but live better. So we know, even from London to the slums in Glasgow, in Scotland, health promotion plays a role that says everybody must have a role in their own healthcare. And when things go terribly wrong, when we need repair, we have the hospitals and we have primary care, the GPs and the pharmacists and the dentists and the nurse visitors, right? It's exactly the same in palliative care. Palliative care is everybody's responsibility, not just the palliative care doctor, not just the palliative care nurse, not just the allied health people who work for us in palliative care. You and me and your neighbours and your workplace and the schools and the churches and temples and the local government and your neighbours all must play a role in palliative care. If we leave it up to the health services alone to do palliative care, we will not win. We will never provide a quality service. Health is not just the hospital's responsibility. Everybody plays a role. And end-of-life care is not just the palliative care team's responsibility. So, okay, so we got a pretty good idea about why we're doing public health palliative care and who it affects and who's involved. So what are the main practice methods? Well, the main practice methods really come down to things like community development, social ecology of health, civic policy development, public education. But I always like to start by talking about what compassion is, because people often ask me, Allan, what did you mean when you said compassionate communities or compassionate cities? Okay, so the most important thing to say is that a lot of people think compassion means kindness. Yes, compassion does mean kindness. A part of compassion means kindness. A part of compassion is about empathy. But for some people, true empathy can never come because you can never really put yourself in the shoes of somebody whose experience you've never had. So kindness takes that place as well. So empathy and kindness, they help each other. But there is one more thing that separates compassion from caring. And it's this. Compassion means reciprocity. Let me say that again. Compassion means reciprocity. In public health, we don't have patience. We don't do things on people. That's a clinical model. The clinical model is the patient comes into the room, or we go out to the patient's house, and the patient has no power, very little knowledge, and we do things to the patient. We do an investigation, we carry out a physical examination, we prescribe medication, etc., etc. That's not compassion. Compassion understands that we share the care. We share in each other's suffering. And we share in the happiness of that care. Any family member or friend who's ever cared for a dying person knows one important thing, which is the dying person cares for them. That's really important. The care is reciprocal. We don't just care for dying people also care for us. If we only care for bereaved people, they're our patients. But bereaved people have things to offer too. We really want dignity at the end of life, dignity in grief, human dignity in facing our own deaths, then we have to be allowed to be what we are normally are, people who give and take. We can learn from dying people. We can be cared for by dying people. We can learn from caregivers and from people who live with grief and bereavement. They have a lot of practice wisdom and they have a lot of insight that they can share with us to help us understand, because they are us, or we will be them soon if we are not already. So that reciprocity means that we must allow ourselves to be cared for by these people and encourage them to be active in their own health and well-being. They must be active. They're not our new patients. They are citizens. And they are everywhere. Bereaved people are in the golf club and the art galleries and in the workplace. People who live with a life-limiting illness are also to be found in the golf club, the football club, the soccer club, whatever, the art galleries, the neighborhoods. Not dying people are not always lying in bed, you know, right? So that reciprocity is terribly important if we are to ensure that we provide dignified palliative care. And the key method for that is what we call compassionate communities. Compassionate communities are community development programs. They are grassroots programs. They are neighborhood programs. It's where we encourage people within the same kind of geographical local area to look after those who have advanced aging, who are very old, who are people who are living with life-threatening or life-limiting illnesses, people who need support from us with caregiving. Caregivers need a lot of help from other people to avoid the isolation and loneliness and all the other things that we mentioned before in the social epidemiology of dying, caregiving, and grief and bereavement. The social ecology of health tends to be much more top-down. If community development is grassroots, it's developing the neighborhood, then the social ecology of health is being able to introduce civic policies in the workplaces, among the trade unions, the churches, temples, and mosques, in the playground, in schools. So we need civic policies that basically say, look, people will die in our workplace, or they'll live with serious illness in our schools, in our workplaces, in our churches. How can we develop a policy that will support them? What is our role to do this? So this happens at a big city level, normally. Towns, 100,000, there are cities around the world already, more than 1 million people are developing this in all the different workplaces and all the trade union movements and all the churches and temples and all the schools. That's what we call social ecology. We are manipulating the physical and social environment to produce a climate and a culture of compassion. So civic policy development is terribly important, as is public education. Public education is terribly important. You know that for your own health. What food is best to eat versus what food you shouldn't eat. How much beer or wine or vodka, you should drink these things. People know about quantity. So they're educated. There's a certain literacy around healthcare, and they need to have some literacy around end of life. The way we do this, of course, is we use our art galleries, we use our museums, we use our schools, we use our festivals. So it's really important to have festivals of remembrance, festivals that celebrate caring and also recognizing the grief and loss in every community. We must bring the end of life out of the shadows. And festivals are great ways to do that. They get people talking to each other, swapping their experiences and learning from each other. That reciprocal learning that is so important in the development of compassion. How do we do that? We provide leadership. We don't want doctors not to be doctors. We don't want nurses not to be nurses. But we want the services, the health services, the palliative care services, to take leadership, to talk to the Chamber of Commerce, to talk to the Archbishop, to talk to the media and the newspapers and the TVs and the internet, to develop encouragement, to develop the civic policies we need to see around us. That will only come if you pick up the phone and visit people. As a palliative care service, you need to get the civic society on your side. You need to say, what are you doing? What is your bit? What role are you playing to help us in palliative care? And then we create partnerships. We redesign services. So in primary care, we can team up with community development organizations, for example. Even in primary care, as well as palliative care, we can have partners who are community development organizations and education institutions. And we can use what we call the Compassionate City Charter, which is a map of all the different civic elements within a society. Currently, there's thousands of compassionate communities across lots of different countries, including yours now. Thanks to Alexander and a few other people in South America, there's lots of compassionate communities. There are beginning them in North America as well, lots in Canada, lots in the UK, lots in Europe. We have dozens of compassionate cities who are using the Compassionate City Charter. We have a biannual conference series. We had one just recently in Belgium. There's an international professional association called PHPCI. We have an international journal for the public health movement called Palliative Care and Social Practice, published by SAGE, that has an impact factor of 2.7. We have a national UK charity, and there's a new Oxford textbook as well. If you want to know more about the public health movement around the world, to connect Brazil with what everyone else is doing around the world, then I invite you to have a look at the website for Public Health Palliative Care International or the one for Compassionate Communities UK. And of course, our recent book, the Oxford textbook of Public Health Palliative Care, gives you lots of examples of practice examples from compassionate communities around the world, compassionate cities, policy development, reviews the evidence base for this kind of public health movement, as well as giving you some idea around policy and the history of the movement. I hope I'll eventually make it to Brazil and meet you all, or meet many of you. But for the moment, I'm inspired by you that Brazil has taken this remarkable step into the world of public health palliative care. It's a brave step. It's a big step away from just clinical work, but it's the only step that ensures we have quality end-of-life care for everyone. Thank you very much.